we're assuming the person in front of us has been through and has a story that arrived them there, they're not just a set of symptoms. We're going to want to show up authentically.
Welcome to Normalize the Conversation by Inspiring My Generation. I'm your host, Francesca Reicherter. Today, I'm joined by Olivia Verhulst, a licensed psychotherapist, wellness consultant, and Forbes Health Advisor, whose work focuses on making our systems more trauma-informed and compassionate. Together, we're diving into what trauma-informed maternal health care really looks like, and how curiosity, awareness, and empathy can transform the way we support new moms. From understanding postpartum depression and perinatal OCD to recognizing trauma responses and asking better questions, Olivia shares how small shifts in language and care can make a life-changing difference for mothers. It's time to rethink how we show up for mothers, for families, and for one another. Olivia, thank you so much for joining me today. I'm super excited because I had you on the podcast over a year ago, and you were just so amazing, breaking down so many myths about therapy and self-care. And now I get to learn from you again. But before we begin, I want to check in. How are you really?
Great question. First of all, thank you for having me. I love following your journey on social media since the last time that we met and just staying connected to you. I think that you are truly inspiring your generation. So it's been a really cool thing to watch you grow over the years. And how am I really? I am great. If you asked me 3 weeks ago, I would say probably not so well. I was definitely kind of emerging on burnout maybe a month ago at this point. But I had the opportunity to go on a vacation, to prioritize some friendship time this past weekend, which we know is so important for burnout, and a lot of family time and some great bed rotting. So I'm feeling pretty good today.
I love to hear that. It's so easy to get to that place of burnout, especially working in a field that has so much empathy. And to be
Yes,
able to recognize it's okay to take that break that we need to reset is so important. And that's often not a conversation that we have in today's world. It's usually keep going, keep going, keep going, produce content, don't prioritize yourself feeling content. It's hard.
absolutely. And I literally actually just stepped off an interview with News 12 in New York on burnout. So it's fresh in the mind. It's fresh in the mind, yeah. And I teach a lot to my counseling students about what you're referencing, compassion fatigue and vicarious trauma, which is just repeated empathic engagement with a lot of the world tragedies that we're seeing show up on our screens every single day. So definitely a lot there.
Yeah, it is so, again, not something we often talk about. And it wasn't until my trauma class that my teacher had even brought it up. And for
Mhm.
the first time, I was like, okay, so when I'm feeling extremely burnt out and overwhelmed, and I feel like I'm shutting down, that's okay. That's normal. It's happening to other people, and I can reset for a moment. Like, this is something that we're all experiencing because it felt so personal. Because when you go online, it seems like everyone's life is so great all the time, and they're so happy
Mhm.
and they're going and going and going. I always
Yeah,
think I'm the only one feeling that way.
definitely not, especially as someone in the mental health space working with just again that repeated empathic engagement with very raw and traumatic and human struggles. I mean, yeah, it's a lot right now. And I would say burnout is pretty normal in our field, I hate to say. And I think what is becoming more normalized is encouraging therapists to take breaks, to model for their clients. It's okay, it's great to go on vacation or to take a mental health day. And I find that my clients are always like, go on vacation, enjoy. And I'm like, heck yeah.
I love that. It is such a good thing to model for your clients as well, to know even I take my own advice. Even I can feel burnt out and overwhelmed, and taking that break, that time to reset can make a difference. Maybe
Yeah.
they're more inclined to do it too.
Absolutely. Yeah.
So today we're going to talk about something I have not talked about before, which is trauma-informed maternal health. I'm really excited for this conversation for many different reasons, but as a person who's recently graduated and has seen clients in both a clinical aspect, getting my trainee hours, and then just as someone who's an advocate and constantly in different settings, there's hasn't been a lot of education for me on trauma informed. And
Ooh,
when there has been, it has never, from my experience with me personally in
yeah.
conversations, been trauma informed maternal health.
Ooh, okay. Yeah. I mean, where to begin? Should we start with like what trauma-informed care really is?
Yes.
So it's so interesting because when we hear the term trauma-informed provider, which really at its core stands for and means, they are prioritizing, generally speaking, these six pillars of care in its safety, collaboration, peer support, um, cultural and gender responsiveness and humility within their care, asking permission and collaboration. So you would imagine, oh, and also it's operating off of the lens that people are more inclined to have a trauma history than not, which we know through research is true, right? Most people do have a trauma history when you get to adulthood. And so you would think that that's like, well, that should be all providers. That's like the baseline, right? That's the least that we could do. And in fact, what we have found is that's not true. And trauma informed care is really avoiding re traumatizing the client or the patient. And oftentimes it's on accident that we do that. And so this is a practice that we need to be in and be aware of. And it's funny because you said before, I haven't really heard about, or I haven't really spent a lot of time learning about what trauma informed means. And yet you've been in a, is it, remind me your degree or remind
Master's of Marriage and Family Therapy.
yeah, like you're in a mental health program. So it's always so interesting to me that that does tend to be the norm. So I do kind of create my classrooms as an adjunct at NYU around like a trauma-informed classroom space to kind of model in real time what we're doing. Anyway, I could go on, but that is trauma-informed care at its root, and we can keep developing and deepening that definition here.
In my trauma class, we had presentations on different types of trauma someone may experience, and it was like, what can you do? Teaching them self-care and coping skills, grounding techniques, mindfulness, but it was never broken down in a way of a trauma-informed approach, and recognizing that anyone and everyone could have a history of trauma. It doesn't have to be these really big things like a natural disaster or an assault to be considered trauma.
Right. And if you're asking that question of how would my behavior be different as a leader, as a professor, as a therapist, as a doctor, if I was operating off of the lens that the person in front of me is more likely to have a trauma history than not, you can imagine that likely we're going to have increased sensitivity. We're going to have increased awareness over the tone and our demeanor, right? If we're assuming the person in front of us has been through and has a story that arrived them there, they're not just a set of symptoms. We're going to want to show up authentically, make sure that we're managing power differentials in the room and dynamics there, and be aware of kind of the basics like emotional regulation tools that we can readily offer the person in front of us, among so many other things.
That makes so much sense. So I have a question. Hopefully
Yeah,
it's not a silly question. But for
never.
for a therapist, so what I learned is in our intake, for example, right? You
Yeah.
ask any history of physical sexual abuse.
Mhm.
But then if they say no, we just never really bring it up again. But it seems like maybe because those words are used, someone's like,
Yeah.
well, I haven't had physical abuse. I haven't been sexually assaulted, therefore I haven't had any trauma. How could
Yeah.
we actually kind of begin to explore different types of trauma and open up people to explore how that impacted them and how it's impacting them now?
Yes, that is such an important question. It's something that I talk about as a professor so often, because I think a lot of students are wondering, I have friends or I have family who I would say they've been through trauma, but they wouldn't say that. How do I navigate that in real time? And the answer is so multifaceted. I'll say a few things that came right to mind, and hopefully it kind of gets at your question. There's so much training that precedes this question. So I just want to put that out there for your listeners and your viewers. But at the end of the day, we're meeting the client where they are, right? I'm not entering into the space to push my agenda or goal of getting them to see this thing. What does happen is organically over time, with the pursuit of self knowledge that is the therapy space, things tend to be divulged more as we create that really safe therapeutic alliance. Psychoeducation, I offer to clients when they are receptive and ready for that. And then another key point here is that you mentioned intakes, right? It's a checkbox, quick thing. And we have to imagine we're doing this with a stranger that we've either just met or we haven't met yet and we're meeting, say, tomorrow or next week. So, yeah, the information that they offer is likely going to be limited. Why would it not be? We're complete strangers. I do believe trust is earned and built in the therapeutic alliance. Sometimes you'll have someone who's really clear, like, hey, I'm coming in to work on X, Y, and Z and my sexual trauma history or this patterns of abusive relationships I've been in and understand them more. And that's amazing. And other times, that type of goal is something that we're developing together as we clarify goals together, and that's fine. And a last point that I would say there regarding like an intake is the way that I teach my trauma class is that we are gathering a trauma history sometimes across 6 months. Like an intake, gathering the real story of someone's past, it's not going to just happen in that first hour session. Sometimes we're collecting that information across a very long period of time because that's the work, right? That's how humans operate, and that's okay. So meeting them where they are is definitely key.
Yeah, and one thing you said over and over again is together, right?
Yeah.
Develop these goals together, meeting them where they're at and working through this together. A
Yeah.
lot of times, I think I'll say on the patient end, as someone who's spent so much time in therapy, is a lot of times I look to the therapist to tell me what to do, what to say, and what should my goals be. And I just assume that they know everything. And they know
Mhm.
a lot from their education and training, but
For
not
sure.
my experience as we were learning my experience together. A lot of times I didn't, for a very long time, I didn't realize I actually had a say in my therapy process. And I thought it was
Oh,
supposed to be in control of someone else completely.
yeah, you're describing perfectly that pillar of trauma-informed care that we named before of collaboration and mutuality or peer support, right? We're doing this together. And don't get me wrong, I am a very active, engaging therapist. I'm not the blank slate therapist who is unmoved and unfazed by the person coming in the room. Like I'm very relational and dynamic in my work. And even then, there's still a way to be non-prescriptive and still be able to support and guide. And I think that that's really where that collaboration piece comes in. Checking in, asking permission, explaining how the body scan that we're about to do together typically impacts people and what to expect during it, right? Informed consent and transparency. So that's what I mean by, together, right? This is a relationship, the therapeutic alliance.
Yeah, I love that so much. I haven't thought about it that way. So, my therapist, I'll say from my personal experience, I had so much happened growing up that I didn't register as trauma, but that's been like really impacting who I am and how I show up in the world.
Yeah.
And as this was the first therapist that really brought it to my attention, that like, Francesca, this is trauma. And if you're okay talking about it, I'd like to explore more. And she checks in a lot as we're talking about it. And I had never had a therapist do that before. And I was like, this,
Yeah.
I wonder what it's like when I was working with clients during my trainee hours. Was
Yeah.
I asking, was I checking in enough? Look at how this made me feel as a patient. And I wish that this was a conversation I had earlier.
hmm I think that question of, did I do this right? Did I do all of this perfect? The answer is probably no, because we're not supposed to. We're supposed to go into the field and make some mistakes in the beginning. That is just, it's the way of learning. It's the way of adapting and growing. But I love that you're asking that question and that you do want to move forward with potential future patient work and knowing you probably past patient work too, you have done this, but in a really collaborative way. And I love that your therapist asked permission, like, "Hey, can we talk about this?" That's awesome.
Yeah, it really is because I am probably one of the most frustrating patients in therapy because I will not like cry in therapy. So when we start talking about a sensitive topic, it is very hard for my therapist to navigate. And I do it too. The therapy room, absolutely. It's totally me. 'Cause I don't want to cry. I don't know why. I will not cry in front of other people. Working on that in therapy.
Yeah.
And so she has learned to check in and make sure that I'm comfortable because I will just shut down if I feel like I want to cry and then we won't get anywhere. So that's been really helpful, just having a therapist who's gotten to know me and who's made the time, the effort to see what feels a little triggering for me and to remember that going into our future sessions to know this is a conversation we need to have, something we need to explore, but we need to do it at Francesca's pace.
I'm really impressed by that. I think that that's fantastic. And you know what? I'll match you and I'll share something that my therapist does with me that I actually am like gonna borrow and use in my own clinical work because it's so great. She often says, I guess she checks in, yeah, at the beginning and kind of asks a question of how can I best support you today? Or yeah, what feels most important today? And it reminds me that I am in a very intentional space and to use it intentionally. And yeah, it just kind of it helps direct the space in that way. So yeah, shout out Ellie.
I love that.
Yeah.
I, yeah, because a lot of times I know for me, I walk in and I'm venting about something like right off the bat, like world is ending.
Yeah.
And we have less than an hour together. And a lot of times there's something that maybe we could have gone into that I completely just overshadowed because I was in a bad mood about something, because I
Yeah.
only had one cup of coffee at that moment and talked to people before my third cup of coffee.
Yeah, yeah. I mean, it sounds like you have a good vibe with your therapist and that she does have a trauma-informed approach with you. Does that resonate?
Yeah. And it wasn't something I had thought about until this conversation.
Yeah.
Something that's come up a lot is I was a competitive cheerleader. I broke a lot of bones, and was in a cast and still being yelled at to compete, even though there was a cast on my arm and I was a flyer and I had accidentally like my arm hit my base, right? And it hurt them because it was a cast. And then I was getting screamed at because my arm should have been closer to me. I was like, I was in so much pain. I did not want to be there. I was trying so hard to not fall on my bases because I could hurt them, especially with my cast that my arm was out just a little bit. And over again for 12 or 13 years, I was going through that breaking bones and being told to just suck it up and figure it out. I had torn 8 ligaments between two
Oh no.
ankles, got screamed at by my coach. They taped my ankles into place and then put a brace over it to make me compete. And then as soon as I stepped off the stage, I would be back in a boot, sometimes in a cast, sometimes being wheeled in a wheelchair. because I could not stand. I was in so much pain. And I just thought that was normal. So now as an adult, it doesn't matter how much pain I am, doesn't matter how overwhelmed I feel. I could be
Mm,
extremely sick and I just feel like I have to keep going.
yeah.
Otherwise, I'm not good enough and I'm letting people down. And she was the first person to kind of connect that for me and help me realize this is something that I went through. Maybe healing a little bit of that and that inner child could help me be able to breathe as an adult.
Oh my gosh, I'm having so many reactions. It's such an interesting concept in general. I know a lot of athletes, and just have had, different athletes in my family and everything. And that question of where that line is between being expected to perform in high pressure and be able to be high functioning on the field or in wherever it is, and to be adaptable and kind of aware that you're going to be kind of pushing past some limits. But where's the line between I am pushed past my limits, or this is an abusive environment, or this is just really unhealthy, or toxic. And so it's such an interesting conversation. But I heard the broader point there that you were making, kind of just being, yeah, there's these earlier life experiences that form these core beliefs and automatic behaviors. And it is on us at the end of the day to make the unconscious conscious. And I'm glad you're doing the work.
Oh, me too, because
Yeah.
I told you before we started, I'm finally sleeping again. I am not working
Mhm.
till 2 a.m. thinking that I have to. I can
Mhm.
actually sleep 6 hours and the smile is real. It's not me forcing it. Very
Wow.
big difference than it's been for years at this point. So I'm
Really.
very grateful. But going back to our original topic of maternal trauma informed care. So, how does trauma informed care now relate to maternal health?
So, those pillars of trauma informed care that we were talking about earlier, ranging from as the provider, we are really emphasizing in our approach to work, safety, collaboration, gender and cultural responsiveness, and humility, and asking permission, among other things, as well as operating off of the lens of people are more inclined to have a trauma history than they are not. That is directly applicable to all things maternal health, whether you're a maternal mental health therapist, as I am, whether you're an OBGYN, whether you are a doula, a nurse, a pelvic floor therapist. So essentially, in terms of how I got here, I co founded with my partner, Liz Gray, who's a licensed clinical social worker in Chicago, the Trauma Informed Maternal Health Directory and Network, because we were both witnessing, whether it be from personal experiences or professional experiences, friends, patients, family, that women, birthing people, were being repeatedly re traumatized in their perinatal care. They weren't being asked permission before they were touched in these really vulnerable and private spaces on our body. They weren't their story and their context, their race, their ethnicity, their cultural norms weren't being seen and recognized in the room as valid and important. And they were really just being seen as a set of symptoms or a person in the waiting room. And things would go awry, and pain would result from this, and people not feeling seen would result from this. And then there's the whole just cultural unconscious around how we treat mothers or don't treat mothers. And so yeah, I mean, there's so many ways in which trauma informed care is relevant and pertinent to maternal health care. I'll start there. Yeah. Yeah.
Okay, I never thought about this.
Yeah.
And that makes so much sense. I actually saw something recently on Instagram. Someone had done a post where a lot of times women's health isn't brought into education settings, right? It's oftentimes it's considered a standard across the board, and we don't think about maternal health care. We don't think about women going through menopause, perimenopause, all these different aspects. So a lot of times we don't even think to ask the right questions because if no one's talking to us about it as patients, we don't know what questions to ask. We don't know what's happening. We look to the professional in the room to tell us. And if the professional in the room has never heard a conversation like this, has never had a conversation like this, we often get stuck in the same pattern of women not always getting the support that they actually need until
Yeah.
symptoms are way too bad to then be like, oh, maybe we missed something. Maybe we didn't approach this in the exact way that was appropriate for my client at that time.
Right. And I mean, when you say that sentence of women not getting support in the way that they actually really need, it's like, that's a familiar narrative that we know, right? We've heard that across the board, across many different angles. But I mean, yeah, I agree with everything you say. And one thing that I was thinking toward the end there is when you do make that inevitable mistake as a provider, you don't need to sit there punishing yourself, especially if you're well intentioned. Use it as a learning experience. Use that energy, that anxiety, that time that you would be ruminating on everything that you didn't do perfectly, instead to consider how did this inform me of something I didn't know before? How am I going to implement what I just learned in the future? And I think that's probably a better use of time.
Yeah, absolutely. Being able to turn these into learning experiences because, like you said in the beginning, you're learning, you're figuring out as you go. You will inevitably not be perfect and make mistakes. And as long as we can take that into a place of intention and being able to learn, that's the best thing we can do. We don't know what we don't know. We learn as we go. We're human beings. More information and research happen all the time. So being able to give yourself grace and come from just a place of curiosity, of learning, and genuine care is
Yeah.
the best thing that we can do.
I think curiosity is at the core of everything we're talking about. It's something that we're trained in as clinicians to be at the core of our work. Never assuming, like leading with curiosity, even if someone says something that feels really relatable to us or obvious to us, let's ask what that means to them. Like I had a mentor once share with me when I was an intake coordinator at a practice that he always asks patients when they get on the phone if they say, yeah, I have a history of anxiety, depression. Okay, but what does anxiety mean for you? How does it show up for you? Because in fact, you learn so much from curious questions like that without assuming, like, oh, yeah, anxiety, they must have restlessness and increased heart rate. Like, no, let's ask how it shows up for them. And then you learn a lot more. And that is the same for all things trauma related, maternal health related, mom related, when we ask follow-up questions.
Yeah, it's so true. How does this show up for you? What does this mean to you? What does this look like for you? A lot of times people can have very similar experiences that present so differently. And
Yeah.
that's okay. And making an assumption can be very difficult. I remember the first time I realized this, I had a client who was telling me about social anxiety at events. And I was like,
Mm.
oh, I get that. I'm always terrified until I talk to someone. And for me, all it takes is saying hi to someone saying hi back to realize that I'm not in a room
Mhm.
of people who are going to hate me and that I can fit into this room. For
Mhm.
my client, though, it was I don't know how to start a conversation. I don't know how to talk to people. I feel very overwhelmed in a large space with a
Yeah.
lot of people and not knowing how I can exit the room. What's my safety? And I had never thought about it from that perspective. And when I had asked the question, which I think was one of the first times I did, I realized although it might be the same almost core feeling of anxiety when walking into a social event, it's very, very different for both of us. And if I told that client just to walk into the room and talk to someone, I would not have been helping in any way, shape, or form.
Yes. Okay, this is great. I love where this conversation is going because it's directly applicable to maternal health. So maybe, I mean, you know, this is a high hope, but if you're like a doctor listening to this podcast, or if you're a therapist working with maternal health clients, that familiar story we hear of the brand new mom a week and a half postpartum who says, yeah, I'm not sleeping. I'm barely eating. I'm feeling really overwhelmed. And it's easy to maybe say, that sounds normal. Yeah. Biggest life transition, most vulnerable time period. Sure. You'll come out of that. That's typical now. Instead, if we were to ask really what the day to day is looking like and feeling like, maybe then what is divulged is the reason that mom's not sleeping is because she's having OCD like intrusive thoughts about the baby's safety or about the baby breathing. And is there compulsions attached to that? And suddenly we have a potential diagnosis for perinatal OCD forming. Or are they experiencing not just the normal kind of shame and guilt we have about being a really good parent on our firstborn or secondborn or whatever, but maybe they're experiencing pervasive shame and guilt that accompanies postpartum depression.
It's, again, not something I thought about, how these experiences, it may seem very standard. Everyone feels this way, of course. But if we don't talk about it more to see what's behind it, we really miss out on giving someone the care and the support that they need. I want to talk a little bit about on the other side too, for patients who are coming in and they want someone who's from a trauma informed lens,
Mhm.
especially with maternal health. What are some questions that maybe they can ask to gauge if this clinician, this doctor, this person is going to meet me where I'm at?
I would say don't even complicate it. Just be really direct in asking if it's important to you. Are you a trauma-informed provider? Right, that in and of itself, I think the term people are becoming more knowledgeable about. Also, maybe if you don't feel comfortable using that specific language, you could ask them, I'm someone with a trauma history. I'm wondering how you work with clients who tell you that they have trauma histories, and how do you bring safety into this provider relationship? So those would be two questions I would think about. How do you prioritize safety?
So direct, so easy. A lot of times we think we can't ask questions so direct. And
Yeah,
we can.
yeah, good point. Yeah, I would say that if this is a provider, again, that's providing a service to you, let's remember that that's why they're there, right? Yeah, ideally they will be prepared for questions like this.
Uh, I am so grateful we had this conversation today. I, so many things I never thought of before, and almost feels silly to have never thought about it. But again, if you're not exposed to these conversations, they're not talking about this in schools, or they didn't talk about it in my classrooms. Can't say across the board. Don't want to make any generalizations or assumptions. But for me personally, not having exposure to these conversations before, this was exactly something I needed to hear, whether it's one side, a future patient in this space, or a possible potential clinician in this space, being able to understand both sides. So I super, super appreciate you for this conversation, for our past conversation, and for everything that you are. As we are wrapping up, how can people kind of connect with you, learn more about your work, and even maybe
Yeah.
access this network that you've created?
Thank you for asking that, and I'll share my answer there. But before I do, I just want to say I really appreciate your vulnerability. The way that you're able to say things like, I feel silly. I didn't even know this before. I think that's such a normal feeling. But again, if we're in a culture that is generally speaking kind of mental health and trauma illiterate, it actually makes perfect sense that it hasn't come into your paradigm yet before. And I'm glad it is now. And knowing you're already doing a lot of these things. So while language can be so powerful, my hope is that a lot of clinicians are already doing these things.
Yeah.
So I just wanted to say I always appreciate your vulnerability on these conversations and from what I see that you're doing out there. And you can find me, again, my name's Olivia Verhulst. I'm a licensed clinician in New York, New Jersey, and Florida. You can find me on Psychology Today. I also do some other things like I do media, news, and TV appearances, kind of educating and advocating on mental health topics. But then my company that I co-founded with Elizabeth Gray is the Trauma Informed Maternal Health Directory. Also, the website is just maternaltraumasupport.com. And if you are a patient looking for a true trauma-informed provider or therapist or doula and things like that, you can find hopefully a provider on the website. We are growing. We're still in our early stages, but we're growing. And then if you are a provider that wants to be on the directory and join our network, we have multiple different membership benefits at a pretty low costly rate each month. So you can find us there.
Olivia, thank you again so much for joining me today, for all that you are. I really, really appreciate you. For our final wrap up of this conversation, can you offer one last piece of advice to our listeners?
Oh my gosh. Okay, let me think. Let me think. Hmm. You know what? A theme that we were talking about today, kind of inadvertently, but it did come up, is like this place of self-compassion and forgiveness and not like punishing ourselves for making mistakes or not knowing something prior. And I want to emphasize that point today is like, we're not supposed to know everything, right? We're supposed to go out there to learn by making mistakes, trial and error, asking for more information. And I'm just hoping that listeners can walk away with a little bit of increased self-compassion this week and availability to say, I don't know the answer to this, and that's okay.
Thank you so much for listening to Normalize the Conversation. Don't forget to subscribe, rate, and review. This podcast is an initiative of Inspiring My Generation, focusing on normalizing the conversation, bringing education and awareness to the forefront, and amplifying global voices to spark change and hope. Inspiring My Generation is a 501c3 nonprofit organization on a mission towards suicide prevention through awareness, conversation, education, and support. Connect with us on Instagram at Inspiring My Generation and visit our website inspiringmygeneration.org to learn more about our work and how you can make a difference.